welcome back, welcome back. The next segment I'm really excited about because I had to learn the hard way. As a patient who's had it since 2019, I learned the hard way to understand when I need to and how much medication I need to take. So this is Dr. Patel, movement disorder specialist at OhioHealth, to talk about how medications work and tips for taking them effectively. Let's give a hand to Dr. Patel.
Thank you. Good morning, everybody. So I'm going to spend the next 20 minutes or so focusing on Parkinson medications, the different classes of medications that are out there, and kind of go through a brief overview about each different category and side effects, dosing, things like that. So lots of information in the next 20 minutes. Try not to get overwhelmed, but it's just going to be a quick snapshot of what's available and what's out there. So Parkinson's disease in general, so one thing to always keep in mind is that Parkinson's is not a cookie cutter disease. No two patients are the same. Everyone is different, right? We know, and so when it comes to treatment for Parkinson's and when we're treating Parkinson's, is that everyone is on an individual plan. Everyone is on a different medication regimen, a different cocktail of medications that works for them. Just because something's working for your neighbor, that may not mean that that's going to be the drug that works for you, or vice versa. So always keep that in mind, especially when you're getting involved in groups and things like this, and you become more involved with the disease, and you start reading about things online, and Dr. Google tells you about all sorts of different things. That doesn't necessarily mean this is going to be the thing for me. Always ask your doctor about it, but one thing to always keep in mind. And the main goal, we know that nobody dies from Parkinson's. You die with Parkinson's, not from Parkinson's. But it can affect someone's quality of life. So our job as a treatment group, patient, doctor, nurse, whomever, is to work together to not only improve, but maintain the best quality of life. That's the goal. So that's what we're looking at. That's what these treatment things are doing for patients. So I like to use this slide when trying to describe what Parkinson's disease is. One thing to keep in mind, and we're only going to focus on one part of this, is if you think about Parkinson's as a glacier, is you have the tip, that's the iceberg on top, and those are all your motor symptoms. And it's hard to see, sorry about that, but you have, that's the slowness, slowing down, not moving as quicker or as fast as you can, being stiff, having a tremor, having balance issues. Those are the motor symptoms. That's that tip on top, which a lot of Parkinson's drugs are focusing on. And one thing to always keep in mind is there's a whole slew, there's that big iceberg underneath. Those are the non-motor features of Parkinson's. Trouble sleeping, having problems maybe with mood, being dizzy, constipation, sleep issues, and yelling, screaming, shouting in your sleep. All that stuff comes along with the disease that may have happened way before someone had gotten a tremor, things like that. So when it comes to understanding and treating Parkinson's, it's always important to know that you're not just treating a tremor or feeling slow and stiff, but there are lots of other things that are happening underneath that could be going on, and always addressing, main question that I ask all my patients when I'm seeing them in the clinic is, what bothers you the most? And let's work on that. And if that's, hey, I'm just really constipated, okay, let's work on that. We don't need to focus on your tremor and your other thing when that doesn't really bother you. So all these drugs and things that are out there are looking at that top part, but always keep in mind that there's a whole iceberg underneath that can cause lots of other issues for patients, and always bring that up with your doctor. So Parkinson's, which I'm sure we've already gone through today here, is we know it is a overall, not only a dopamine problem, but primarily a dopamine problem where for whatever reason you lost your stores of dopamine before anybody else. If we all live long enough, we're all going to get Parkinson's. For whatever reason, you lost your stores before the next person did, therefore now you're starting to exhibit symptoms. What we know about the disease is, in general, patients have lost at least 80% of their dopamine stores before the tremor starts or before they start really feeling anything. So the target of treatment for when it comes to Parkinson's and Parkinson's medication is to get at that dopamine. How do we get dopamine back in their system? So that's the goal. That's what we're looking at here, is increasing dopamine. So there's dopamine There are things that become dopamine in the brain, and that's what the main drug levodopa is, where it's a precursor to dopamine. You take it, and it becomes dopamine in the brain. There are drugs that mimic dopamine, what we call dopamine agonists, that trick the brain to thinking that it's dopamine. There are drugs that increase the level of dopamine. So there are enzymes in the system that break down dopamine. Well, if we block those enzymes, thereby now you're keeping dopamine in your system longer and therefore getting more effect. So the drugs that are within that category, there are drugs that work in balance with dopamine. There are other neurochemicals in the brain that work in conjunction with dopamine. They work to off-balance each other. So sometimes if we target those things, we therefore then can modulate and increase the effectiveness of dopamine. And then there are other receptors that work in conjunction with dopamine that can also help you move a lot easier. The anticholinergic medications, which we don't really use anymore, it's an old-fashioned drug that was also used to help primarily with tremor. But just the overall thing here is to show that there's a lot. And there's lots of ways in which we could help patients and kind of focus on, well, which one is the right one for me? Within this category, there are, as you can see here, there are lots of drugs even within each category. Each category of these meds have lots and lots of medications that are potential options for treatment of Parkinson's. And we'll kind of touch on each category and kind of give you a snapshot of what each of the main drugs are within this diagram here. So levodopa. When levodopa was first discovered, if you guys saw the movie Awakenings, it kind of focuses on this. Levodopa, we thought we cured Parkinson's. Levodopa became dopamine. And okay, Parkinson's lack dopamine. Here you go. Take levodopa, we cured Parkinson's. Nobody tolerated it. Everybody threw up. And it threw up because levodopa became dopamine in your gut. And when it becomes dopamine in the gut, you get nauseous. You throw up. So that's why there's that carbidopa component. So it's carbidopa / levodopa. What carbidopa does, it carries the levodopa to the brain for it to become dopamine in the brain where we want it to, which is why you have that 25/100, whatnot. That's what that is. It's Sinemet. Sinemet in Latin means sine without emesis, without vomiting. So that's what Sinemet means. And that's where, so that's what levodopa does. And it's still to this day the gold standard treatment for Parkinson's disease. It is still the best drug. All the new things that are coming out work pretty much in conjunction with levodopa. How can we make levodopa better? What can we do? But to this day, this is still the gold standard treatment. There are lots of different types of levodopa. There is the controlled release version. The controlled release version I use primarily for patients who are feeling in the morning they're just slower and stiffer before they get the day going. So you take a controlled release overnight, so you have a trickle of dopamine all night long so your body's not so deprived first thing in the morning. Another time to take it is for some people who don't tolerate, for whatever reason, that immediate, when you take a regular carbidopa levodopa, it's an immediate release. There's a rush of dopamine that happens in your system, and you feel better, you feel good. But sometimes that rush, you really don't like. You may feel dizzy, you may feel nauseous, and it just doesn't feel good. So then we switch over to maybe the controlled release where you may not feel that immediate good, but at least you're tolerating it, and it's that trickle throughout the day. And you still have to take it 3-4 times a day like you would the regular one. It's just, you don't get that rush. But it works very well. Rytary and Crexont are the newer versions, which are capsules, and inside the capsule there's microbeads that have beads of immediate release and controlled release to give people an extended benefit of levodopa, so you may not feel that fluctuation. In general, what happens as disease progression, which we'll get to, is that you may notice the drug feels good, but then it doesn't last as long. And that's not that the drug doesn't work, it's just that the disease is progressing. And when the disease progresses, we have to then adjust in the way we take our medications to give you that continuous good on feeling throughout the day. Lots of different kinds. There's now a 24-hour pump that just got approved. And most common side effects, nausea still is the main one. One thing you'll notice as we go through these slides that a lot of these side effects are across the board for all the drug classes. In general, carbidopa levodopa has the safest profile in terms of side effect profile. The other drugs tend to be a little bit more potent in terms of side effects, but this one tends to be overall the safest. So when do we start taking it? How should you take it? So generally speaking, we usually start taking it 3 times a day. 3 times a day does not mean morning, noon, and night. 3 times a day means breakfast, lunch, and supper. 3 times a day while you're awake. It's symptom control. When you're sleeping, there's no point of it. And the only time I make that caveat, like I mentioned earlier, is for patients who are feeling their morning is so slow, so you take a controlled release at bedtime just to give you that baseline. You don't feel so off first thing in the morning. So in general, 3 times a day, and then we do, we know the disease does progress. This is a slowly progressive disorder. When it does progress, then we need to make adjustments to what times and how often you take it, because you may notice you feel good, you take it in the beginning stage of the disease, you take a pill because it's time to take a pill. You feel good overall, and you're good. And then with time, what you may start seeing is that, okay, I take a pill, I feel good, but just, I don't know, half hour, 20 minutes, an hour before I'm due for my next dose, I'm just not feeling right. Something's happening, and then I take my pill and I feel better again. And when that is happening, those fluctuations, we call it, that's when we know we have to make adjustments to the dosing, things like that. If it's bothersome, patients will tell me, yeah, I know it's 20 minutes before I'm due for a dose, but it doesn't really bother me. Fine, leave it alone. But if it gets to the point where, no, it does bother me, then okay, we have lots of options, lots of things to help, to make adjustments accordingly to help you with symptoms. There's a common myth out there that, I don't want to start levodopa because I heard it only works for 5 years. That's not true. It's always going to work. It's always going to do what it do. What happens in 5 years, you start noticing the disease is progressing. So as the disease progresses, we now have to adjust levodopa accordingly to make it so your symptoms feel better. So if you need the drug, you need the drug. There's no reason to not start the medication if you need it, and no reason to wait to take it because you're afraid it's only going to work for 5 years, because that's not true at all. The dopamine agonist category, these are mimics of dopamine. They trick the brain. They work in receptors, the dopamine receptors in the brain, to make it think it's dopamine when it's not. There are 4 main ones, 2 pills, a patch, and Apokyn, which is apomorphine, is an injectable, and now recently there's a apomorphine pump that's also available. It works well, and I like it, especially in younger patients who have tremor predominantly. It tends to have a little bit better tremor control than levodopa does. However, it does have a slightly larger side effect profile. Same side effects as levodopa. The unique things about these ones, sometimes patients can have what we call sleep attacks. They suddenly fall asleep. And the other one to be wary of is impulse control disorder. So little things you like to do once in a while, no big deal. Go to Home Depot, pick up a few things here and there, totally fine. Now all of a sudden you're coming home with truckloads of stuff, that's a problem. Having something sweet, ice cream once in a while, no big deal. Going through pints every day, that's a problem. So those sort of urges that a patient may not realize that they're doing, but we rely on loved ones to kind of be like, something's happening here, because they're spending way more than they should be. They're going through a retirement. What's happening? Why is this happening? That's one thing to be wary of with this class of medication, particularly. Some swelling in the legs. But although all that stuff is rare, there is a risk for it. So I do like it. I like to use them in my younger patients. I think it works very well for them, and they tend to tolerate it better. Older patients may not tolerate it as well in terms of side effects, but a good class of medication to try out. Again, monitor for side effects. This is the new pump that just got approved a couple months ago. One thing to keep in mind when you are on certain of these medications, you can't stop it abruptly. You can go into pretty severe withdrawal. So if you are not, for whatever reason, not tolerating it, always talk to your doctor to figure out what's the best way to come off these meds if you are having any of these side effects, because just stopping it abruptly can potentially cause more problems. So this was what I was talking about earlier. In the beginnings of the disease, your therapeutic window is very large, and you take a pill because it's time to take a pill. And then with time, what you notice is you start, that same dose is just not taking that, it's taking longer for it to kick in. When it does kick in, it tends to overshoot, and now you start having more side effects. That's the dyskinesia, like what Michael J. Fox does. And then it tends to come down much faster, and so your window gets narrower and narrower. And so these the other drugs that are there to sort of open up that window a bit. How can we make it so that we aren't having those side effects, we aren't having those dyskinesias, and also we're having a quicker onset and the drug is lasting in our system longer. So these enzyme inhibitors, they're there to block the the breakdown of dopamine. So these enzymes, they break down dopamine. So if we block the enzyme, we now have dopamine in our system longer. They're older drugs, very safe, very well tolerated, milder treatments. All they're doing is really just boosting either the endogenous dopamine you have left, so some people can start off on just these drugs, just to see, hey, whatever dopamine there is, can I keep that longer without taking external dopamine? Always an option. Or you're taking dopamine and it's not lasting that long. You could take one of these that could potentially thereby extend the benefit of this one even longer. So works very well. Selegiline, rasagiline, sulfonamide. Selegiline is twice a day dosing. Selegiline breaks down into an amphetamine component. So although you take it twice a day, you want to take it morning and noon. You don't really want to take the second dose much later than that because it may keep you up, and Parkinson patients already have trouble with sleep, and we don't want to do that. Rasagiline is once a day, but again, just similar side effect profiles, just keep monitoring for those things. And then the other enzyme inhibitor, again, works the same way. Entacapone, or picapone is the newer one you take just at bedtime, shown in studies where you get an extended release and extended levels of dopamine in your system, just stays in your system longer. And then when we overshoot, so those we're working on trying to give you more dopamine, and then what happens when you overshoot and get the dyskinesia. I will tell you, a lot of patients, Parkinson patients, they don't mind the dyskinesia. They'd rather feel good on instead of feeling slow and stiff. So when we see patients that are dyskinetic, caregivers, family, loved ones are like, oh my God, they're moving around so much. Like, why is that happening? The patient could care less. Like, I'd rather do that than the other way. Because, okay, I'm doing that, I have too much dopamine. What do I do? Okay, let's not take as much. Well, if I don't take as much, now I'm the other way, I'm slow and stiff. I don't want that. So I'd rather be slight. So the key word there is troublesome dyskinesia. If patients are bothered by the fact that they're moving around so much, then sure, there are things available to help address it. So that's the big thing takeaway, is that you should treat troublesome dyskinesia. You don't want to treat just because you're seeing a patient wiggling, does that mean that they need to be on something or we need to adjust their regimen? Amantadine is the main drug for dyskinesia. Amantadine works in that it works with a different neurochemical to help balance out dopamine. So when we're having too much, you kind of give amantadine to help regulate those dopamine levels to kind of make it balance out and make it smoother. Or immediate release amantadine you take 2-3 times a day, and then there's extended release amantadine where you just have to take it once a day, usually at bedtime. It has a slightly different side effect profile. A couple of things to monitor for that one. Swelling in the legs primarily. You may get like a lace-like rash you start noticing throughout the system, throughout your body. That's unique to amantadine. Hallucinations, confusion, and dizziness, just like all the other drugs. So titrate up slowly. Gocovri is the one that is the extended release that's approved for dyskinesia. That's the extended release one. Isodenafil Noriance, this is working on sort of another neurochemical that's supposed to elevate the levels of dopamine. So essentially what you're doing is, the way dopamine works in the system is you have dopamine that's making you go and move easier. Dopamine, if you think of your body as a car engine, it's the oil to our machinery. It makes things smoother. And when we're lacking it, that's when you start feeling slow, stiff, can't move so well. Adenosine is a chemical that works with dopamine. So you have dopamine, that's like our gas pedal making us go. Adenosine's the brake pedal, like, hey, we're moving too much, let's stop. But if we're moving too slow, well, if we block the brake pedal, now we're going to move better again, right? So isodenafil is a drug that's out there to help to kind of ease up that brake pedal a bit. So it blocks adenosine, thereby we're kind of moving a little bit quicker, a little bit easier. So it works, novel pathway, different pathway, newer drug, but effective in Parkinson's. So once a pill, once a day, still have the same side effect profile, but can be effective. And the last slide I'll kind of touch on the last minute and a half, is this is the main drug for Parkinson's. Exercise, exercise, exercise. They hammered you with it today, I'm sure. And the main takeaway here is it is a slowly progressive disorder. We don't have a cure. And the only thing proven to truly slow down the disease is exercise. Consistently proven. I see it in my patients all the time. I know the patients who are exercising every day and they need less drug. they tolerate the medicine better, they significantly have a better quality of life compared to the patients that don't. There's a huge difference, and it's scientifically been proven. Clinically, every day, real life, we see it all the time. So biggest takeaway I'd say from all those drugs and everything that I touched on is the importance of exercise is going to go way more than any of those drugs will. So extremely important in terms of effectiveness and whatever it is. It doesn't matter what type of thing you're doing, as long as you're moving, you're getting out there and you're doing something. So take-home points, remember, no two patients are the same. Everyone has their own cocktail of medications, treatment profile, things that works for them. There is no reason, if you need medicine, you need medicine. There's no reason to delay treatment just because of what you may hear, what may work for a few years or not. Dyskinesia, when that's happening, we can address it. If it's troublesome and bothersome, there are lots of things out there to help with that. But a lot of times, it's just the fact that, okay, it's happening and I'm good. I know what's happening, it's fine. But if we need to, we can. Keep moving, keep exercising. And my time is up. Thank you, guys.